Talking about future, it's always going to be a tricky thing. Predicting future is never going to be easy. But actually, it's what we will all co-create. That will be the future. But it's important to go through and think about some of the drivers that might drive us for the changes that will co-create the future. And if in the next few minutes I go through those, as you would have imagined, that these talks are quite common these days, and I would have said same things or similar things in many other talks to which you've been there, or some of you have been there. So if it's repetition of content, then my apologies. Right. So I'll go through what the current climate is and where Royal College sits in all that, the landscape that we have for us and the opportunities that are there. So a little bit about history before we look into future. 1846, it was all recognized as something special, and speciality therefore created. 1932, Britain embarked on having association of Great Britain and Ireland at the time, and that was the first formal structure within the UK, and also the oldest structure in the UK related to anaesthesia as speciality. 1948, faculty was created with the help of association in the Royal College of Surgeons. So people like me, not in 1948, but subsequently, applied for fellowship of Faculty of Anaesthesia. So it used to be not FRCA, FFARCS, Fellow Faculty of Anaesthesia at Royal College of Surgeons. So all the exams used to happen at the Royal College of Surgeons in those days in Lincoln Inn Fields. Some of you might remember. And it wasn't a coincidence that at the same time, the faculty was created at the same time when NHS was created. So faculty started in 1948 with members around 150 in the country. So fellows and members, if you think about. 2 members of staff sitting in one small room at the Royal College of Surgeons, looking after the exams and the training and the membership at the time. We've now grown. 2019, we now, within the Royal College of Anaesthetists, have 2 faculties, as you know, pain medicine, intensive care medicine, 22,500 members, about 100 staff, and you're familiar with the building and the work it does. But this is the new governance structure within the college. You have council, 24 elected members, and to those, to the council, the 4 boards, they are reporting to the council all the time. And 2 important ones from our specialty point of view are clinical quality and research, education, training and exams, and one newly formed board, which is communications and external affairs. And all the things that you'll talk about, curriculum, training, exams, equivalence, that sits with the Education, Training and Exam Board. And lots of things that you get involved with on everyday basis, whether it's related to creation of standards for anesthesia services or accreditation, AXA process. I know Nottingham's gone through very recently, and there was a report out yesterday. HSRC, the different projects that you put your data to, NELA, PQIP, NAPS, SNAPS, all these projects are looked after by the Board of Clinical Quality and Research, which responds to which is responsible to the council. BJA and BJA Education, they are the official journals of the college. And we have partnerships with National Institute of Academic Anaesthesia, but also looking out, we work, or this is how the speciality works, basically. You work not in isolation, but with all other medical specialties, surgical specialties, and Department of Health bodies. That's where we sit, and that's the landscape we are in. In terms of our services, patients, and how we work with patients or for patients, this is the landscape. It shouldn't come as a surprise to you that NHS is in red in terms of finances since 2013, consistently in red, and that bar chart is actually going downwards every year. There are challenges with regards to workforce. That shouldn't come as a surprise, although it's not felt that much within anaesthesia community at the moment compared with general practitioners or psychiatrists, but it is there. And of course, patients getting older and patients getting more and more comorbid or having more and more comorbidities. 50% having comorbidity by the age of 50, one comorbidity. And 65% have multiple morbidities, 2 or more, by the age of 65. Well, that's the landscape, and that shouldn't come as a surprise to us. So, if you look at Royal College of Surgeons, they produced a glossy last year, and this was to do with their vision about where future of surgery is going. They mentioned anesthesia once, which is not a surprise. However, it's an important report to look at. If we are in any doubt that in the future the surgical burden or the burden of surgery is going to reduce, then I think that report will look at that myth and prove it the other way around, that actually the burden of surgery is going to increase because the patients are getting more and more sick, and although the surgery is going more and more towards targeted and more non-invasive way, but the duration of surgical operations is increasing, number of surgeries that they'll be able to do within a week or within a day is going to decrease, and therefore the burden of surgical operations as a whole is going to increase. So therefore, we're going to feel more in terms of workforce pressures. So these are the headline figures. If you want to just remember 2 figures here for the time being, it's 10 million surgeries every day. So this is from 2 years ago, and 16 billion being spent. So these are elective surgeries. 10 million surgeries happening in NHS every year. 10 million elective and 16 billion being spent. So that's huge amount of money if you think about it. That's about 10 to 15% of total NHS budget. Talked about landscape, talked all negative things, but here is the positive news. So if you compare NHS with the similar kind of GDP countries or westernized countries, you would see that we perform, in terms of overall ranking, we are at the top, despite all the pressures. Compares with Australians, Canadians, French, Germans, Dutch, New Zealanders, Americans. UK is at the top. But where we do not do really well is, if you look at the outcomes, somehow that's not coming. If you look at the outcomes, right at the bottom row, we are at number 10. So, great NHS in terms of care processes, access, efficiency, equity, but not very good at outcomes. So looking at future, if you were to think about what that will be shaped by, I think better outcomes is definitely going to be on agenda. Of course, there will be scientific advances which will make us change for the good. Shape of workforce is going to be very important. As I talked about, the burden of surgery is going to increase and the burden of morbidity is going to increase. So how are we going to then look after the patients perioperatively? We will need to think about, is it going to be just anesthesia-led service, or has there to be a perioperative team within which there are anaesthetists, there are nurses, there are PAAs, physician assistants, and other physiotherapists, sports and medicine experts, geriatricians. Are we talking about a team approach here, or just looking at the numbers of anaesthetists? Integration of service, I was speaking with Mike this morning. It's not, the legislation currently is there to make it happen. It's at the consultative stage. So once the legislation comes in force, I think what used to be STPs or integrated care systems now, they will have teeth, and the agenda will be to integrate more and think more in terms of joined up pathways for patient care, be it for stroke medicine or be it for perioperative medicine. In terms of outcomes, I think it's important that we think about outcomes in the future, or even at present. What are the outcomes that actually matter to the patients and not to us? So I mentioned 24 council members. 2-3 years ago, I ran a survey among them, did a study, a very small study, to look at what outcomes matter to the council members that we've all elected. And surprise, surprise, after quite a few iterations, was nausea, vomiting, pain. But if you asked a surgeon what would matter to them, they will talk completely different outcomes. It will be bleeding, rebleeding, infection, those kind of things. You ask the patient, they want to go home, they want to walk their dog, they want to go back to work. So those are the outcomes that matter to patients. We need to be thinking more in terms of population health outcomes. And I think that will be the future, because that's what matters to people. Not to say that nausea, vomiting, pain, and all those things don't have impact on population health outcomes or aren't important, but also thinking in those terms and capturing that data is going to be the future. And putting it in the terms of economics and how it's going to make difference to the money side of things, that's where we get into the political domain as speciality. I think we haven't done ourselves justice so far, in the sense that we do have impact on population health outcomes, but we haven't made the case, and we don't appear, as when I said Future of Anaesthesia report, anesthesia appears only once. Long-term plan, NHS, if you look at that, anesthesia as specialty appears maybe once or twice. You can blame them, or you could look at ourselves, have we done enough to make the case? And I think that's where future is going to be, making that case with the politicians, with the public. So science and technology certainly will help. In artificial intelligence, maybe you'll have your sitting here and monitoring patients in Theatre 15 on your iPhones, or maybe even running a closed loop delivery system. That might be the future. Genome and personalized medicine is going to make a huge difference to how we deliver anesthetics, what kind of anesthetics, which drugs do we use for which particular patient's genotype. Surgical report you have to see, and they talk about growth of stem cell technologies and non-invasive methods. And we may have to tailor our anesthetic technique to that. But big data will shape us as to how we provide service in general, not how we work within the operating theatre, but how we provide service. And you participate in huge amount of big data projects, such as PQIP, such as NELA. You're already doing that and looking at that. I would talk about workforce just for a second, because it is quite a big focus currently for the Department of Health. They're thinking in terms of recruitment, and this is workforce in general, not just anesthesia. They're talking in terms of increasing the number of medical schools, and that's currently on card. So our specialty has to have inroads into those medical schools quite early on to keep attracting good graduates to come to our specialty. Retention is very big on agenda. Pensions certainly are there. Morale, welfare, you've heard all that in media. That's very much the focus currently. But the shape of workforce, again, despite it is very well recognized that we may increase the numbers of medical admissions or places in medical schools or number of medical schools, the exact increase in number is not going to be realized for another 10, 15 years. And again, that may not be enough for the surgical load or perioperative load that we will have. So shape of workforce becomes very, very important to think about. We are currently recruiting less than half the numbers required in the next 5 years. Okay, so the opportunities I think that we will need to look at is how can we provide better quality work with less money. And as I said, science technology will help, but it's the delivery of care where the focus has to be. All different big data projects to which you would be giving or you would be providing data. But big ticket items are prevention. Now, often I'm asked, how can we enter in that domain? People are talking about the teaching moments in preoperative clinics, or even before that in GP land. Patients coming for surgery. Is there a case for making? Is that the right time to make a case for anti-smoking campaign or asking them to reduce weight if there's time? And also look at alcohol. So those are very big ticket items, huge population health problems. We have a lot to offer in terms of the outcome of these patients, whether they are obese, diabetic, cancer, patients with cancer, patients with dementia, frailty, smoking or alcohol related issues, when they undergo perioperative period. Prehabilitation, very recent data would suggest just prehabilitation alone, so a bit of exercise, 2 to 3 weeks of exercise before you have your surgery, reduces your outcomes or reduces your complication by 50%, just that. So imagine significant complication rate being halved. So if you think about 10% as the complication rate for elective surgery, which has been in publications, you can see the amount of workload that you're going to reduce and savings you're going to make and impact you're going to have on patient outcomes. Prognostication in itself, just telling patients the prognosis, being honest with them, is very, very important. Many of them choose alternative ways rather than going for big surgical operation, if there are alternative ways, of course, of managing the condition, and especially with joint replacements. It's very much a decision that patient makes based on their overall expectation from the intervention. And often we are not very honest. So therefore, shared decision making is going to be quite important. Why are we not sitting with the GPs and the surgeons when the surgery is being contemplated, rather than saying, well, you can have your hip fixed, and then patient comes with mindset that I'm going to have my hip fixed. Why not talk about, you can have your hip fixed. There are other ways of looking at it, and we can do A, B, C, D. Having hip fixed with your comorbidity has this much risk, has this much. Why don't we do that? And why does that not happen? I think that should happen. And that's where we as specialty need to be more focusing on. Optimizing, of course, enhanced recovery, we do that quite nicely these days. Planned post-operative care, and very important, composite outcomes. It's not just patient leaving hospital, and it's not just patient leaving the ward. It's patient getting back to work and patients getting back to the lifestyle that they expect. PQIP, you've seen, and that's highlighted some of the interventions we need to make. But I think PQIP still does not address, it looks at perioperative, if you think, often if you talk to people about perioperative period, they say, well, we do it already because we have a pre-op clinic and we look after patients, and patients go to ward and we have post-op rounds. So most anaesthetists of my generation, that's what you will hear, that they say, we do it already. But actually, if you look at PQIP, it goes, the umbrella spreads out a little bit further. But if you think about perioperative medicine as a whole, it needs to go even further. We need to go into community, so beyond drinking, eating, and mobilizing, into community, whether that has had any impact on cognitive function, on patients getting back to work. Similarly, anemia, diabetes, at the time of admission, yeah, that's fine, but if you go even before that, at the GP land, you pick it up early, before they present for surgery, or even surgery is contemplated. If there is room to improve that, you improve that. Patients love it. There are lots of stories that patients come up with, and they say, individualized prognosis and plan and comprehensive preparation, they just are for it because it changes the mindset. You're not saying to them, oh, you've got to wait for another 3 months for your operation. What you're saying is, you've got 2 to 3 months to prepare for your operation. You can actually improve the chances of coming out of it in a much better shape than otherwise. So all that really helps. Why is it important? So you remember so this is a slide from PQIP data. Irrespective, so what you see in the blue sort of circles is the number of days that you spend on an average for that particular surgery, which is either abdominal, head and neck, thoracic, whichever surgery. So your average length of stay within the hospital is about a week. But if you have one or more significant complications, that is extended 3 times, so about 3 weeks. So if you think that 10% of people undergoing elective surgery have one or more significant complications, 3 times increase in the hospital stay. This is a recent data from PQIP. Put that in that equation, 10 million surgeries, right? 16 billion being spent, okay? 10% suffer complication after surgery, which extends the hospital stay. So if you halve that by prehabilitation, you're making huge savings in terms of it, and we're not talking about just millions, billions for NHS. Bruce Keogh was the previous medical director, would publicly say that 1 in 7 surgeries are unnecessary or preventable. In private, he would say 1 in 5 are preventable. I looked at data comprehensively. From 1956, so a year before I was born, till today, there have been at least 18 papers that I've seen which look at preventable operations. So consistently, from about 60 years now, there is, so of course data is quite spread, but anywhere between 10% to 25% surgeries are preventable, and that's quite consistent. If you think about that, even if you have a little bit of impact on that by shared decision making, there's a huge case to be made there in terms of billions of savings. So, talking about services, outcomes, let's now concentrate on future of our specialty, because that's the talk. We trained as specialists, and one of the side effects of that is that we all think in terms of specialism. So you talk to people, they say, well, it's not my job. GP should have done it. Or this is not my job, surgeon should do it. If you ask patients, they don't care who does it. what they care about is that this happens. And I think that is the opportunity for leadership that we need to grasp. And I must say, my younger colleagues, I was having a similar talk in Wales the other day, and there were 5 presentations from trainees, 4 of which were to do with perioperative medicine. So younger trainees coming up, ST5, ST4, coming up and saying they found that 20% of their patients' colorectal surgery were anemic. They went to the GPs. So these are trainees who went to the GPs. Maybe you can do that in Wales. So they went to the GPs, sat down, they had common protocol, and they got a hematologist involved, and all those things. So they weren't thinking in terms of, this is not my job. So moving out of that specialism mindset. So I think we have our curriculum, we have our training, we have our practice, but getting out is the future, because if we are highly trained, skilled individuals working in a very narrow environment, that can be challenged. And there are countries where it has been challenged. And the role of anesthesiologists, as for example in America, is very much in threat currently, because the nurse anesthetists can there show that they have similar outcomes, if not better. So how do you then keep justifying spending that much of money or paying that much of money for that kind of skilled job? So being a doctor, I think, is more important in terms of specialism. And as a specialist, of course, being an anesthetist is very, very important. This is how I started practicing. Hand on pulse. Well, of course, we didn't have bow ties, but literally just one piece of equipment, hand on pulse and patient. And this is where I feel I am now, one-man band. So it's a lot of equipment, a lot of stuff to do before operation, just morning, half an hour before patient's ready for surgery, and then half an hour after patient. So it's quite busy day for you, because you're having to pack everything and having to do lots of things in very small space of time. I think I would like to see that this is the future for us, a leadership role in perioperative medicine, making sure that what patient wants happens, which is good care is delivered. Who delivers it, how it is delivered, what's the shape of workforce, is something we need to co-create. Sit down. So who plays which piece of instrument is what we need to think about, rather than thinking in terms of one-man band that we need to play everything ourselves. And for that, you need partnership with surgeons, GPs, nurses, patients, of course. And that's happening within the college. So we are very much looking at different partners. I've spoken with the presidents of Royal College of Surgeons, general practitioners, nurses. They've all come on board. May this year, we'll be launching Center for Perioperative Care. And the job that this center will have is to pull all this data together from various audits and from various initiatives. Look at that and then come up with service guidance, what an ideal perioperative pathway should look like. And we're going to start with diabetes. So Diabetes UK have come on board, and also working with Macmillan on patients for cancer. So these are the first 2 big ticket items that we're going to grapple with in Center for Perioperative Care. Hopefully, once we've done the gap analysis and pathways and produce guidance, the next challenge will be to get that embedded in tariffs and practice, because unless that happens, the whole concept will not materialize. So we've had very good conversations with our current NHS medical director, Steve Powis. Completely buys the idea, and the time is right in terms of integrated care systems coming in, and the tariffs now moving away from individual episodes, such as how many hip surgeries have you done, to more focused on outcomes. We have a room here for influence. public, media, and politicians, very, very important as part of that machinery. So just to summarize, I think money is not going to grow. If at all, it'll be less in the future compared with the burden. Quality is going to be a major issue. Yes, science and technology, but individualized care for that particular patient, shared decision-making, integration of services, looking at outcomes beyond what we traditionally look at, and increasing our sphere of influence, and therefore taking that leadership role in the management of perioperative care for a patient. I think that's the future. Thank you very much.